Okay, good evening, everybody. Thank you for joining us this evening. My name's Rachel, and I'm one of the specialist nurses here at Pancreatic Cancer UK. I'm pleased to be joined today by two specialists in diabetes. So we have Karen and Bev from the Royal Surrey County Hospital, who will be talking about understanding and managing diabetes alongside pancreatic cancer. We know that often this can feel quite tricky, so we hope you'll find this really helpful and practical. Before we get started, there's just a few quick housekeeping bits to run through. And I'm also going to share a bit about the services that we have to support you here at Pancreatic Cancer UK. So just to let you know a few bits of housekeeping. So we will have a question and answer session at the end of the webinar. So you should see a Q&A icon on your screen. There's a picture of it there. It looks like two speech bubbles. So to ask a question, just type it into the box, and please feel free to ask questions throughout the session. You don't need to wait until the end. And just to be aware that any questions you ask will be visible to everybody. So you can choose to ask a question anonymously if you'd prefer to do that, or you can upvote questions by pressing on the thumb icon, and that'll just take them further to the top. In some cases, it might be that people are asking very specific questions or questions that perhaps fall out of the scope of today's webinar. So that we can keep the questions and answers as relevant to as many people as possible, we may reply to you individually in the Q&A box, and that might be offering support or signposting to other means of support or information, or perhaps suggesting that you give our support line a call. Rather than reading the question aloud. So hopefully you'll understand our reasons for doing that. If you are joining from outside the UK, you're really welcome, but just keep in mind that the information we will give will be based on the UK health system, so we won't be able to advise on options elsewhere. Just to let you know that the webinar is being recorded, so we will make the recording available on our website afterwards if you'd like to watch it back or share it with other people who might be interested, and we'll email you a link with that when it's all ready. Okay, and then just before we crack on, there's a bit there about feedback, so it will be great to get your feedback as well after today's session, and I'll talk about that a bit more at the end. So I'm now just going to move on to talk to you about some of the support that we have available at Pancreatic. Or directly affected, or if you are a family member of somebody that's been diagnosed. So Pancreatic Cancer UK's message is clear, and that we want to be there to support people impacted by pancreatic cancer, whether they are directly impacted or a family member or friend of someone diagnosed, as I was saying. And ideally, we would love people to know about our support services from the time of diagnosis, as we know how difficult that time can be. So I'm just going to briefly talk through the support that we have on offer. So our most well-known service is our national telephone and email service, which is open to anyone impacted by pancreatic cancer. The service is run by the 7 of us specialist nurses, or specialist pancreatic cancer nurses, of which I'm one. We've all worked previously within the NHS in a variety of settings. Some of us have been specialist nurses specifically for people with pancreatic cancer. Some of us have worked within chemotherapy setting or in the surgical setting. Others of us have more background in palliative care. So hopefully we have a lot of experience as a group that people calling or email can benefit from. And there are many reasons why a person may call us. Some people may call us when they've just been given the news of their diagnosis, their head is spinning and they really don't know where to turn or what will happen next. Some people may call following an appointment or perhaps after a phone call. People might be in a state of shock or may not have taken in the information that they've been given, or they may be unsure about what the next steps will be or have questions. They may be struggling to understand the medical terminology that was used. So it can be really helpful for people in these sorts of situations to call us, as we've got time to go through things in detail, hopefully answer questions and offer some practical suggestions. It can be also useful for people to speak to us, as we are independent of any NHS team, and people are free to ask what they may consider to be silly questions, although they never are silly questions. But perhaps sometimes people feel a bit easier about doing that. Some people may call us about treatment options, perhaps chemotherapy. They may be due to start chemotherapy quite soon and have lots of questions, for example, about how chemotherapy is given or what the possible side effects might be. And these people really want to discuss their concerns and anxieties about that. Some people call us because they or their family members are struggling with managing physical symptoms, such as pain or nausea and sickness. And we can explore this in more detail and hopefully make suggestions for a way forward. So one thing we hear often is that people are struggling with diarrhea, they're struggling with loss of appetite and loss of weight. And we know, loss of appetite and loss of weight is a very common reason why people will call. So we'll give them advice on diet and nutrition, and this will include information and advice on taking pancreatic enzymes. It might also include things on diabetes, if this is relevant, and obviously we'll be coming on to more of that shortly. And we recognise that it can be really helpful for people to speak to the same nurse, so we do our best to try and ensure that a specific nurse stays with a particular person throughout all of their contact and gets to know them and their situation. After a call, we're more than happy to provide personalised information, whether that's via email or post, and this can help summarise what we've talked through and perhaps cover what the next steps might be. People do call us on numerous occasions, which is lovely. We sometimes organise follow-up calls if somebody would like that. And we really encourage people to pick up the phone as and when they need. And we see it as a massive privilege getting to know people and families at a time that is often tough. And our priority is ensuring that people don't feel alone, but that they know we're there for them as and when they need. We know how devastating, or can appreciate how devastating, a diagnosis of pancreatic cancer is. And so you can be assured of our help and care and support. And we know it's a brave thing to call, especially at first when someone doesn't really know what to expect. And we do have some lovely feedback, and there's a couple of quotes there. And also just to stress that we do have the email service as well, and we know that some people prefer email, that works better for them, and they're just a lot more comfortable with that. We recognise that having written information is really important to people, so that they're able to understand their condition. And at the charity, we've developed a whole range of information on pancreatic cancer, whether this is information to help a person understand things when they're first diagnosed, or whether it's specific things like chemotherapy, or in that picture there about diabetes, which can happen alongside pancreatic cancer. Our information is reviewed by health professionals who have a lot of expertise in pancreatic cancer, and it's also reviewed and has input from people that have been directly involved themselves, directly impacted themselves. So our information can be read online via our website, or downloaded from there, or we can arrange for publications to be posted out free of charge. And we also aim to make our information as accessible as possible in a range of different formats. And we also have some really good videos on our website on specific topics, and sometimes that might be more helpful for people if they would rather watch than read. We have developed a virtual programme of support for people impacted by pancreatic cancer, various topics, and we usually have one of these sessions most weeks. They last for an hour and a half, although if that's too long for people, then they're able to leave as soon as they've had enough. They're facilitated by one of the nurses here, and they're on Zoom. So I would just say that they're really relaxed, friendly and informal, and people can say as little or as much as they like. And people can find it really beneficial to chat or listen to other people going through similar experiences and difficulties, and people can share with each other things that have perhaps helped them. It's also an opportunity to ask questions and understand certain topics. And we also have social cuppas, and one for people directly impacted, and one also for carers. We have one of those each month as well. We have our online discussion forum, which is a supportive place where anybody affected by pancreatic cancer can be there for one another. It's a place where you can discuss everything from how to navigate through the hospital system to how someone can talk to their family about their diagnosis. It's a community of supportive and compassionate individuals who can really relate to an individual situation and offer support and a listening ear. And then finally, one of the services that we have available at the charity is called Side by Side. So this service is for people that are due to have surgery for pancreatic cancer or have recently undergone surgery for pancreatic cancer. We also can invite family members to be part of this too. In a nutshell, this service links up these people with a trained volunteer that has previously undergone surgery for pancreatic cancer. So these people speak on the phone. It might just be a one-off call or a series of calls, depending on what the person prefers. And it's just a great opportunity for a person to speak to someone that has been through surgery, and they're able to ask any questions that they may have and really talk through what their concerns or worries are, whether that's before surgery or perhaps as part of their recovery. And people tell us how helpful this has been for them to talk to someone that has had first-hand experience. So thanks for listening to that, and I hope that was helpful to hear about the ways we can help support you. It would be really good to be in touch with you if you haven't been in touch with us before. And if you do have any questions about anything that I've just mentioned, do feel free to pop them into the Q&A, and we'll cover those a bit later on. So we're now going to move on to the main bit of our webinar, to look at pancreatic cancer and diabetes. And it's great to be able to welcome Karen and Bev. So massive warm welcome to them, and we're really grateful to you for being able to be part of this event. So I'll pass over to them. Thanks.
Thank you, Rachel. So hello, my name's Karen Mackie. I'm the diabetes specialist dietitian at the Royal Surrey Hospital. And we've got Bev. If you want to introduce yourself.
Hi, my name's Bev Tuthill. I'm one of the diabetes specialist nurses at the Royal Surrey.
So Bev and I tend to work quite closely together, basically supporting people with diabetes, whether it's type 1, type 2, type 3C, gestational, so anything relating to the blood glucose management. So that our role is particularly more in the diabetes side of things. At our hospital, we do have an HPB team as well. So it's a team who work alongside people who've gone through some sort of pancreatic disease, pancreatic cancers. and we tend to work alongside them as well in terms of referrals we receive for diabetes management as well. We do want to say just from the onset, the presentation is going to be fairly general, because unfortunately we can't do anything specific for individual people. When it comes to the management, it is very individual. It's dependent on what are your results showing, and working very closely with your team. What we're hoping though is that from the discussions today and from what we've mentioned, you will know sort of what to look out for, what questions to ask, and who to go to for further support. All right, so I'm just going to, Bev, do you want to do the introduction side?
Sure. Okay, so what we're going to cover today in our discussion is the different types of diabetes, so giving a brief overview, specifically type 3C diabetes, the treatments available for the management of type 3C, the nutritional management of, we're talking specifically of type 3C diabetes, and obviously we'll explain exactly what that means. And the challenges and importance of glycemic control within the management of type 3C diabetes. So first of all, what I'm going to do is give you a brief overview of different types of diabetes. Okay, so starting off with type 1 diabetes, this is an autoimmune condition. So it basically, the body, for whatever reason, we still don't know why this is, attacks the insulin producing cells, leading to absolute deficiency of insulin. Now, insulin is a hormone which facilitates the shift of energy from the bloodstream into cells, muscle, and the spare energy is stored in the liver. So type 1 means there's no insulin at all, and the insulin has to be replaced. And this makes up probably about 8% of our diabetes population in the UK. Now, type 2 diabetes, I think everybody is kind of familiar with. This is the majority of our diabetes cohort. And this is very much about insulin resistance and moving on to insulin deficiency. So what tends to happen in the type 2 is that you have resistance, so the body requires more insulin to do the same job, which can then result in beta cell exhaustion. So you have a deficiency plus an inability to produce as much insulin, and there we then have resulting problems. With type 2 diabetes, your starting point is always lifestyle, and then you move on to escalating treatments. Okay, so MODY is a genetic type of diabetes, makes up a very small percentage. It's a deficiency in one gene. It's a monogenic diabetes form, so a mutation or a change in a single gene. It's very familial, so it's very kind of related to family. So if you've got somebody in your family with MODY, then we would do genetic testing to see if, you know, you were likely to carry it, or potentially it was in the family. So moving on to gestational diabetes, which is obviously diabetes developing in pregnancy, often in the 2nd or 3rd trimester. So the hormones that obviously, you know, allow a baby to grow do play a part in increasing resistance to insulin, but additional factors can be age, your weight, your ethnicity can play a part in this as well, family history. Usually resolves when baby arrives, but if you've had gestational diabetes, you can be more predisposed to type 2 diabetes in later life. Now, the main focus of what we're talking about today is actually type 3C diabetes. So this is a concurrent deficiency in both pancreatic endocrine and exocrine function. So basically, type 3C diabetes tends to be secondary to a pancreatic disease, which can involve both of these functions of the pancreas. So the disease could be starting off with a pancreatitis, it could be a cancer, it could be surgery, or any sort of combination of the above. So when we're talking about the endocrine function, we're talking about the insulin production being affected. So those beta cells that produce insulin. And the exocrine function means the production of the digestive enzymes can be impacted. So you can potentially have a situation where you're unable to properly digest your food, and then you have not enough insulin to actually shift that energy, resulting in various problems, which we're going to talk about trying to manage in further on in this discussion. Go to the next, yeah, there we go. So the pancreas is a soft oblong gland located deep in the abdomen. And so we're divided into the head, the body, and the tail. The beta cells are the most abundant islet cells in the pancreas, and these are the insulin secreting cells. So obviously, if you've got some sort of disease of the pancreas, it depends on what part of the pancreas is affected. You can have deficiencies in insulin, you can have deficiencies in enzyme production, or you can have deficiencies in both, which becomes quite tricky. The alpha cells secrete glucagon. So this is quite important because it's the counter-regulatory hormone to insulin. So additional energy is stored in the liver. When your blood glucose levels drop, your pancreas produces glucagon, which basically knocks on the liver and says, oh, you can have a bit of energy to keep my sugar stable. So if you have a deficiency in this, you can have some trickiness around managing low blood glucose levels. So the exocrine production is this production of digestive enzymes. So we have a picture here of the normal pancreas, and you can see it's deeply enmeshed in various other organs. It's very centrally located, surrounded by major vessels. So surgery in these situations, as I'm sure a lot of you are aware, it can be very complex, or even in certain circumstances inoperable. Okay, so moving on to pancreatic disease.
Bev's already touched on the different functions of the pancreas. Basically, just to break it down a little bit, so we know that the pancreas is really responsible for a lot of the digestion in our body. That's why it's located so close to the stomach and the duodenum and that. So the enzymes that are secreted by the pancreas are actually there to break down the fats, the carbohydrates, and the proteins that we eat. So if there is a problem with the pancreas and these particular cells which produce the enzymes, without those enzymes, it's very difficult to absorb nutrients because it's not digesting properly. And then some of the consequences are people will lose weight, there can be deficiencies, and it becomes a complicated scenario there. Generally, the pancreas will release these enzymes, they'll sort of become active in the duodenum. And then the other thing that happens is it also produces bicarbonate, which basically neutralizes the stomach acids as well. So there's a lot that the exocrine function of the pancreas does. They've spoken about the endocrine. So this is very much the hormone part of the pancreas. And there's a lot of different cells within the pancreas which produce different hormones. So Bev's mentioned the insulin. So insulin is predominantly there to help control glucose levels. So when glucose levels go up, the increased insulin will help to bring the glucose levels down within the bloodstream. Whereas glucagon is slightly different in that when blood glucose levels tend to dip quite low, the glucagon kicks in. Our body has a store of glucose generally within the liver. So when our levels do drop, when we haven't eaten for a while, all of those times, the glucose level, the glucagon kicks in and it releases glucose into the bloodstream. So we've got this constant supply of glucose and this balance within the system. There's also somatostatin. Basically, it's once again, it's linked to this whole balance between the hormones.
In terms of pancreatic disease leading to diabetes, we know that pancreatitis is the commonest cause of type 3C diabetes, and pancreatitis can also extend on leading to pancreatic cancer. There are other reasons for developing pancreatic cancer, but the complexity of type 3C is the challenge when you have the endocrine cells and the exocrine function is both affected. When there's basically not enough digestive enzymes to break down food, so the release of energy is restricted, leading to a reduced nutritional state. And this is where we're looking at PERT or pancreatic enzyme replacement therapy, such as Creon. The endocrine cells may also be damaged, resulting in reduced insulin production. So you've got higher blood glucose levels, and this in itself can lead on to those osmotic symptoms. Some people may be experiencing things like, we call them the 4 Ts. So you've got thirst because your body's trying to flush out this additional sugar. You're going to the loo more frequently because you're thirsty and you're trying to flush out this additional sugar. You're going to be more tired because the energy is stuck in your system and it's not able to get into the cells and the muscles. And you're going to lose weight because you're literally flushing energy out of your system, which is what we need to address. Okay. In addition to, you know, an insulin deficiency, there might well be a glucagon production issue if the alpha cells are damaged. And glucagon, as we said, facilitates the release of stored energy from the liver. Glucagon is quite difficult to replace, but to be aware of a deficiency can make managing low blood glucose levels more difficult. So it's what we try and do when we've got type 3C and we're doing enzyme replacement and we're putting insulin is we're trying to balance the levels so that we get a decent sugar level, that any additional energy that you're taking on board sticks and you're not symptomatic of high blood sugars. So we try not to, I mean, we don't restrict diet from our end. We try to catch up with medication to kind of keep levels stable so that weight loss is not a massive issue.
So I'm just going to share, this is a very simplistic slide, so please bear with me. I don't know if anyone's heard before about this lock and key analogy that we often use to describe what's going on in the blood in the body in terms of managing blood glucose levels. So basically what the diagram here is showing is that puffy cloud there is basically a cell in the body. It could be any cell, it could be a muscle cell, a lung cell, a heart cell, basically any cell in the body because they all require glucose. And then the yellow dots, basically, that's the glucose that's basically moving through the bloodstream. Now, the bloodstream is basically our transport mechanism. It enables things to get to the cells or get removed from the cells and spread throughout and sort of move to the different parts of the body. And just the same way, glucose is transferred throughout the system in the bloodstream. Now, what tends to happen in terms of any type of diabetes is it's this whole mechanism of transferring this glucose from the bloodstream and into the cells where we actually need it for energy. Every cell will tend to primarily utilize glucose as its first source of energy. So those little lightning bolts, that's basically the glucose, it's in the cell and it's providing energy for the system. Now, the key is the insulin. And we mentioned earlier that the insulin is produced in the pancreas. So you've got your pancreas producing these insulin keys. So that's the sort of analogy of thinking of that key is basically there to unlock the cell door and to enable that glucose to enter into the cell and provide the energy. So when we're looking at particularly type 3C diabetes, which we're thinking of now in terms of the pancreatic functioning there, if the cells in the pancreas have been damaged and can't produce this insulin, those keys are not getting to the cells and therefore the glucose tends to build up in the bloodstream and that therefore you don't get that energy where you need it, i.e. into the cells. So it sort of leads on to the next slide, which basically speaks about why do we need to get our blood glucose levels under control. And there are a number of different reasons for this, but obviously if the glucose levels are quite high within the bloodstream, the body's quite intuitive. It tries to find another way to sort of manage this. And as Bev said, those symptoms that you might experience, things like thirst. So if you wean out a lot of glucose, because that's one of the ways the body does it, you'll be losing a lot of fluid as well. You'll need to drink a lot more. And it becomes a little bit of a spiral. You see, you go to the toilet more, you drink a lot more. And then the other thing is if the glucose isn't getting into the cell where it's needed for energy, you can feel quite lethargic. So that can be another one. Fatigue can be another symptom. Some people get things like temporary blurred vision. It's only temporary. Once the blood glucose comes down, it tends to settle. So there's a number of different symptoms that you may experience if the levels are quite high, and we want to try and prevent that. We want to keep it nice and stable so you're out of that sort of symptom, out of the sort of immediate symptoms. Another thing with glucose levels is it's really, in terms of improving wound healing, our body requires a sort of fairly stable blood glucose level. Particularly if there's an infection or something. Bacteria love glucose. It's a fantastic breeding ground for bacteria. So if the levels are quite high, it can be slower in terms of wound healing. And certainly if you've undergone surgery, if you've undergone sort of treatments, trying to get that wound healed as fast as possible is obviously really important. So trying to level the glucose levels out can help with that. And once again, if there's any sort of cancer treatments or anything you're undergoing, once again, trying to stabilize the blood glucose levels is important as well. Thinking about longer term, obviously for a long period of time, if our nerves are coated in this glucose, it doesn't like it, it can cause a bit of nerve damage. The same thing long term, if the levels are high for a long period of time, there can be circulation damage as well. So we're trying to protect against the immediate. So here and now, we are trying to prevent mainly the symptom control, wound healing, getting through treatments and that. But then longer term, it's also trying to prevent some of the underlying things that can potentially happen. Okay, so I'm going to pass on to Bev now.
So healthy blood glucose ranges. Okay, so I've got my air quotation fingers out, and I'm looking at if we look at non-diabetes blood glucose levels. Okay, so in somebody who doesn't have diabetes, we're thinking somewhere between 4 and 7 millimoles is kind of normal. But this is a very individual thing, especially if you're going through treatments, if we're throwing a bit of steroids into the mix, if we don't have that glucagon response and there's a risk of hypos, it's very, very individual. But I would say generally, we're looking to keep blood glucose levels below 10, okay? In the international blood glucose target range, anywhere between 3.9 and 10 millimoles is perceived to be in range in anybody who's suffering with who is managing diabetes. That's quite happy. It's normal to have an excursion in your blood glucose levels after eating. It's just how long does it stay high before it comes back down again. So what we're trying to achieve is stability in the blood glucose levels, not loads of variation, for levels to come back down to a decent range below 10 after eating or after a feed or supplements. If there's a risk of hypos, we might set your targets 6 to 12 rather than below, so that we're not kind of, you know, falling out the bottom all of the time. So it can be very individual. So it's something to discuss with your medical team so that you're on the same page. Okay, so it's very individual and unique to you depending on what you're trying to manage.
So when looking at treatments, it's a two-part sort of management approach. So obviously diet is going to be one of the factors. And I think one of the key things, if someone has been referred to me with pancreatic cancer or type 3C diabetes, as a dietitian, one of the things I'm trying to look at is that it's not massively restricting the diet. And we've spoken about some of the things, so you can lose weight, your body's going through a lot of stress, so it's not really the time that we want restrictions in place. It's basically the focus is maintaining good overall nutrition from the dietitian side of things. We do go through about carbohydrate awareness, and I'm going to touch on that a little bit later. It's just knowing the type of foods that are going to directly turn into glucose in the system. And then it's working with your team in terms of how do I manage that, because you don't want you cutting anything out. It's basically, when I have this, what do I need to do? How do I approach it? And certainly if you're on insulin treatments, seeing a dietitian can be quite helpful, because we can chat through for you individually what the best approach is and how to progress with it. Okay.
Okay, so in terms of medication, when we're sort of managing type 3C, the recommendation is insulin. It obviously really depends on what part of the pancreas is impacted, but generally we end up using insulin. It's the most reliable. I mean, most other medications such as metformin or gliclazide or various other oral tablets that you can take depend on there being some insulin production. So some endogenous insulin production, and if we don't have that, then the alternative is actually using insulin. So we kind of know the expectations when we're managing with insulin. It's much less likely that we're going to get what we need if we're throwing some glic at it. Okay, so we're basically trying to emulate what was happening when your pancreas was functioning happily. Okay, so we're trying to replace the insulin that your body can no longer produce. So if the body uses insulin all the time, so there's a kind of little trickle in the background happening, and to replace the bolus that your body would throw out when you eat something, we would use a different type of insulin. So there are various different types of insulins available. So most people start off with a bit of basal, so that's a long acting. You have 1 in 2 injections a day. So you've got some insulin in the background, kind of taking care of business, keeping the energy in the liver and mopping up a little bit of spares. If we have lots of postprandial spikes, like every time you eat, you'll have high sugars, or you start the day okay, by the end of the day, you're really high, we might need to put some mealtime insulin, which has got a different job to do. It's much faster acting, and it deals with that rise that comes from eating. Or we can use mixed insulin that has got a bit of intermediate acting, a bit of rapid acting. We'd have that twice a day with breakfast and evening meal. That's very important. You have it with food. So there's different insulins around to manage, with a different focus, a different job to do. So basically, the liver releases glucose during fasting, and we consume glucose in forms of carbohydrates. So we do need insulin in the system all of the time. I've got some demo pens here if I'm able to sort of share my screen. Is that possible, Karen? Do you have the skills? Because I don't. So this is a demo pen, but this is what an insulin pen looks like. So it's pre-filled with 300 units. You can use it multiple times with a fresh needle each time. And we would just screw the needles on, dial up the dose and inject. So it's not too intimidating. Actually, the worst thing about managing blood glucose levels, I think sometimes, is actually the monitoring. But yeah, so that's what an insulin pen looks like. Okay, thank you.
At this point in our slides, we've got a little bit of a break. We thought it might be worth, if you want to just have just a couple of minutes if you need to get a drink or anything, and then we're going to come back and I'm going to talk a little bit about the nutrition side of things. All right. So I'm just going to close my video at the moment, but please, if we can just meet back again, probably in the next 2 or 3 minutes, if you just want to have a bit of a break, and then we'll come back. Okay. Basically, what we're going to go through now is more the nutritional aspect of managing type 3C diabetes, but particularly pancreatic cancer. As mentioned earlier on, healthy eating obviously is probably one of the focuses from our side of things. You have got, I don't know if everyone's seen the Eat Well plate. So on one of the NHS websites, so Live Well has actually got this diagram on the screen. And it basically just indicates the sort of balance that we should have in the diet to get all our different nutrients. So you have this large section, which tends to, but almost a third really, is your fruits and vegetables. And we know these are important for fiber, for nutrients, for antioxidants, for quite a large range of things. So trying to get plenty of fruit and vegetables. Then another large category is your starchy foods. So anything like bread, rice, pasta, potatoes, any of those foods. And in the Eat Well plate, it can be confusing because it's quite a large group. And I know in a lot of cases when we talk about diabetes, many people think, oh no, I should avoid those because they're starchy foods. And in fact, in terms of a balanced diet, that is also part of a balanced diet. So cutting them out isn't always the right approach. Including them as part of a balanced diet is generally the advice that would be given. Obviously switching more towards the whole grain options if appropriate, but generally it's still quite a sizable amount of our diet is coming from starchy foods. Then in their smaller categories would be your dairy foods. So they're our main sort of source of calcium. So certainly including your things like milk, yogurts, cheese, any of those things. Then you've got your protein side, which is really quite critical. If someone's had sort of pancreatic cancer, going through any sort of illness, really, our body goes into sort of more of a stressed state, and sometimes people do need a bit more protein in terms of building up, repair, trying to fight off trying to fight everything. So the protein would be things like eggs, meats, chicken, anything like beans and lentils or your legumes, fish. So trying to get those, and obviously trying to go for the lean options in terms of heart health and that, but certainly including some good sources of protein in the diet. And then there's normally a slither, which is your fats and sugars, but it's all part of a healthy diet, trying to keep that balance. So we're trying to keep that at the back of our mind as well when sort of advising around the diet. But when someone has had pancreatic cancer, it is quite common that people have experienced quite a lot of weight loss. Their appetite's probably going to be impacted as well. So In terms of quantities on a plate, probably not as much as they used to be able to manage. And if you were to just rely on 3 meals a day, it might be quite difficult to meet your requirements. So you may be advised, if you do see a dietitian, or if you do get some advice, it may be a matter of trying to have small and often. So having your main meals and then small snacks in between, because it's easier then to get in the extra nutrition when you've got those small snacks. Healthy fats are often recommended. So if you can't eat a large quantity to try and get all those nutrients in, sometimes it's a matter of adding healthy fats. A small amount of fat has a lot of calories in it, and it actually can be quite useful if you're trying to build yourself up again. But looking at the healthy fats, things like avocados, olives, sort of olive oils, vegetable oils. Sometimes people may be advised to have a bit more, add in some creams, or going for sort of full fat dairy products. And this is where that discussion with your team is really important, to find out what is going to be the approach that's best for you. Some people may be prescribed supplements. So these are the nutritional shakes, and there's quite a range of them. So I guess it depends where someone's located in terms of what supplement you may be prescribed. But normally they're milkshake based drinks. And you may be advised to have them between meals, just to try and top up what you are having during the day from the diet. But with all of this, it's looking at the individual element of it. When I see someone, I will generally do a diet history. I'll find out what sort of things they are managing. There may be some things that you just can't tolerate, and it's working around that to find out, okay, what is better suited. So trying to work with the team just to find the right thing for you. Obviously, if you've been prescribed enzymes, now I mentioned earlier on that we're trying to get this glucose from the bloodstream into the cell where it can be used for energy. And this is where the insulin comes in to do this. But along with that, if your body's not creating the enzymes used for digesting things like carbohydrates, if it can't digest the carbohydrate, it's not releasing the glucose as readily. So when someone starts taking enzymes, which is important, it helps to break down, give you the nutrition your body needs, makes it a bit available to the body. If you start taking enzymes, you may find that your blood glucose levels start going up. In fact, sometimes that's actually a good thing. It's showing that now your body's able to digest the nutrients, and it can now release that glucose into this bloodstream. So some people might find if they've had to increase their enzymes, or they've just started taking them, there might be this rise in the glucose levels. But that's where the diabetes team come into play, because they'll be looking at your insulin, or whether you do need insulin, and just chatting through what are the options to help manage that. But yes, it's really much a discussion and finding out with the team the best way to treat everything. So I do go through in terms of carbohydrate education. Carbohydrates are the main food group that break down to glucose. So you've got all your starches and all your sugary foods, they break down to glucose. So if you have a large quantity of starch, for example, it will break down to more glucose. So your glucose levels might be a little bit higher. Whereas if you only have a small quantity, it's probably not going to produce as much. And it's looking at that balance. And you will probably start noticing, as you're looking at your diets and that, you'll notice things that affect your blood glucose more than others. And blood glucose testing is really critical to this, because what affects one person doesn't necessarily affect the other one in the same way. So it's just working out, when you look at your diet, is there a particular meal that sends your blood glucose higher than others? And it's chatting with the team. With carbohydrates, quite often we'll start slowly and just get people aware of the carbohydrates, what foods are likely to do that, to affect the blood glucose. And then we'll progress slowly. Some people will be adjusting their insulin based on the amount of carbohydrates. And that's with following discussions with the diabetes nurses, the diabetes dietitian, chatting through how to count the carbohydrates and then appropriately adjust. Some people might just stick to the same amount of carbohydrates so that they don't have to adjust their insulin very much. But it's once again, this is a discussion with the team and getting that education, just asking for some support to get their carbohydrate counting advice, or just to create more of an awareness of carbohydrates in the diet. Things like fats and proteins, they don't directly break down to glucose. So it tends to be more of a focus on the carbohydrates. But I think one of the key things is don't cut it out. it's work with the team as to how can I have this and manage my blood glucose levels alongside it, really. Okay. We're going to just talk briefly about some of the factors that can affect blood glucose apart from the diet. So I'm going to hand over to Bev so she can briefly go through this one.
Okay, so there obviously, I mean, food is the obvious thing that impacts on your blood glucose level, but there are other things like activity levels. So this makes being active makes the body more sensitive to any insulin and can cause levels to drop. And this doesn't necessarily mean going to the gym. It can be just moving a little bit more than you usually do, pottering around in the garden, doing more housework. You know, all of this can impact on your blood glucose levels too. So it's to be mindful that if you feel a bit out of sorts, to check your sugars and take some sort of hypo treatment. Okay. Alcohol, if you're a grown-up and have a civilized aperitif or a glass of wine with dinner, it shouldn't really massively impact on blood glucose levels. It's if we have let's say a celebration occasion and we have slightly more than a civilized glass of wine, it's about the impact the alcohol has on your liver. If your liver is busy dealing with deaminating alcohol, it's not as able to produce additional glucose, so there is the potential to drop sugars a little bit, and this can be a particular problem overnight, so it's just to be mindful of that. So the recommendation we give, especially to our youngsters, is rehydrate, get a bit of carbs on board, and don't do anything crazy with your insulin. Okay, I think that's probably reasonable advice for everybody. Stressors, whether these are emotional, physical, psychological stressors, they can cause a resistance. Okay, cortisol levels rise and you become more resistant to your insulin. So sometimes you, in certain circumstances, you might need more insulin to do the same job. But equally, to be mindful that when those stresses are removed, insulin, blood glucose levels can drop quite radically. So it's having, you know, a little bit of preparation for all eventualities, really. Another issue that can cause rises in blood glucose levels because of resistance is infections. So any signs that sugars are going up and you can't quite figure out what's going on, you might have an infection brewing somewhere. Even minor illnesses like a virus or a cold can cause increases in resistance, and again more medication to bring the sugars down. Pain is another thing that's a big stressor, so that can also cause resistance, and when the pain is taken away, you might have this massive drop in requirements. So it's just being mindful of that. As Karen's mentioned, if you have enzymes that are actually doing what they want them to do, and there's more food digested, more energy is going to be released into your system, and blood glucose levels can rise. So again, it's how we treat that. So it's escalations in insulin. People have this kind of thing with insulin doses where they think, oh, that's my dose and I don't change it, but actually it's a very fluid thing. It's responding to what you need. It can be altered, rapid acting on a meal by meal basis, your longer acting maybe over a couple of days, but we're constantly kind of tweaking so that we get the results that we want. Another thing that really kind of can throw a spanner in the works and is quite often a big part of any treatments is steroids. So prednisolone, dexamethasone, they can really cause a massive spike in blood glucose levels. And if you know that, it's not so scary. But if you have treatments which include some steroids or a couple of days of steroids, then you can see these big spikes in sugar. So quite often we have people where they have insulin treatment for a couple of days and then they massively back it off, you know. So it's knowing what's going to happen, understanding what's going to happen, and kind of managing that. So it's not all a big scary ride. But yeah, steroids and some other medications can really cause big rises during the day. But there is a treatment for that. There is a way of managing it.
So that is pretty much just sort of a summary of what we sort of, in terms of managing diabetes, and it is very much an individual approach, so please excuse us if we keep talking about the individuality, But we do see a wide range of people, and it is very much adjusting to the individual and having those chats with them and just open discussions about what is actually impacting them and what's important at the time, really. So we work with and just be mindful of everything that you've been through and that people are going through. There are some websites, so the NHS Eat Well Guide is up there. If you're interested, just doing a bit of a Google type on that can sort of direct you just towards healthy eating, really. Diabetes.org.uk also is another good site for diabetes information, and there's a lot of stuff that you can pull off on there as well. And it's just signposting really to the different services.
There is much more information out there about type 3C diabetes and the complexity of managing a deficiency in insulin plus the enzymatic issues as well, because we know that it is a bit trickier to try and balance those sugars. We've seen Karen and I've seen lots and lots of people on very creative insulin regimens because that's what works for them. So that, you know, it's a way of managing what works for you as an individual. So, you know, no matter how bizarre the regimen, if we get the sugars that we want and people are not symptomatic and they're maintaining their weight and they feel okay, then that's the way we go.
Yeah, absolutely. Brilliant. So thank you very much for listening. We're just going to hand over. We've got some questions that some people have put up, so I'm going to hand over for the discussion here.
Thanks, Karen and Bev. That's really great. Yeah, so we've got quite a few questions. So do feel free to keep putting any questions that you have into the Q&A box. We do actually have some people that have joined by phone today, which is great. So if you are joining by phone and you would like to ask a question, then if you raise your hand by pressing the asterisk and 9, I think that's right, you should be prompted to unmute yourself and speak. But obviously for people that are joining online, we'll just continue to use the Q&A box. Okay, and hopefully, yeah, we'll keep a close eye on if anyone by phone is asking a question or, yeah, okay. So we'll just come to the first question that we have. So, so this one says, I recently understood that Creon can cause the blood sugar to rise. So I take 8 to 10 with bridge in stages of 2 at a time throughout a meal. And the question is, do they have a major impact or is it negligible? Don't know who would like to answer that, or if that's
Yep.
Karen, shall we come to you? Or
yeah, no, that's so basically, as I mentioned through the session, with the enzymes, basically they're there to digest our food, and if you're not able to digest it because your pancreas isn't producing the enzymes, you're not going to get that energy into the bloodstream. The glucose isn't going to enter, so there's not so your levels will probably be on the lower side. When you start taking an enzyme and it starts enabling that digestion to happen, you're now going to get the absorption of glucose from the gut, which is a good thing because it means that you're now actually absorbing that glucose. Your digestion's now occurring. You can now get those nutrients your body needs. So you may find if you've started Creon, and certainly if you're taking it through the meal, you may find that your levels might be going up a little bit more because your body's now actually able to absorb that glucose. And then it's just working with the team in terms of how do you manage it. If my blood glucose is going up, we respond to that rise in glucose. Basically, what we tend to do is we look at those blood glucose patterns. And if we can see that rise and there's a trend there, there's going to be a discussion around, okay, let's try and manage this with maybe more insulin, or just discussion with your team around that.
sorry, on mute. Brilliant, thanks, Karen. Yeah, I guess it is really important that people are taking, you know, the right dose of Creon, because in people that have pancreatic cancer, you know, nutrition is so important. So we do know that it can create more challenges with the blood sugar, but it is really important that people are taking enough pancreatic enzymes. So the next question is, my father has recently been diagnosed with pancreatic cancer. He previously had type 2 diabetes, but is now on insulin to manage high blood glucose levels, as well as taking Creon. No one has mentioned type 3C. How do you diagnose type 3C, and how would we initiate a diagnosis?
It's difficult to know whether the labelling really is all that important. I mean, if you've started insulin, and with pancreatic cancer, we would automatically say that is the diagnosis of type 3C, and it's a bit of a sliding scale. There's a lot of people, even who don't have pancreatic cancer, who can slide from type 2 or type 1 into type 3C, and it's about that exocrine function being affected, as well as the endocrine function. So what's more important is that the management is being carried out, so that blood glucose levels are managed rather than the label, to be honest with you. Type 3C in the world of diabetes is more of a known phenomenon. So we know that when the pancreas is impacted by cancer or surgery or pancreatitis, that you have this, not just the insulin affected, and this is the point of it, but the digestive enzyme aspects of it affected, which creates a slightly more complex management challenge. So it's very much about the awareness around, okay, we're treating the high sugars, do we need enzyme replacement therapy as well? And if we do, how do we manage the sugar? So for me, the label is less important, but the management is, if that makes sense.
No, definitely. Yeah, I completely agree. And I think in terms of perhaps some people struggling perhaps to access support, if it is type 3C or the right support, then I guess, I don't know what you would say about that, or, you know, I guess it's about trying to find somebody that has some knowledge of type 3C diabetes, and hopefully that might be.
What I would like to think, but we're quite fortunate because ours is that we work in a hospital as a tertiary centre, so you've got this big HPB centre, and we have lots of associated services with it. So what I would like to think is that other people have access to that. I know that's not always the case, where you have a diabetes team, and if you have a diabetes team, they will have an understanding and awareness of type 3C and the additional complexity to trying to manage that. That's what I would hope, that anybody managing diabetes has an understanding of this.
That's really true. And I guess it sometimes can be challenging to find a person that, if you know you're in a smaller hospital. So I guess hopefully we might be able to help you on the support line about if you're struggling to access support. I'm sure that it might just be a bit more challenging to actually get to that person, but the support is there, but sometimes it can just take a bit of time and effort to get to them. Okay. The next question is I've heard type 2s are getting recategorized as type 3C. Doesn't this add confusion? And wouldn't it be better to have cancer-related diabetics separately categorized?
It's a difficult one, isn't it? Because with type 3C, it's when you've got that combination of enzyme and insulin requirements. It's when the cells of the whole pancreas have been affected. So we do have some people who actually had type 2 diabetes. So they had insulin resistance, and in fact, it might have been a genetic thing, it might have been a weight-related thing. For numerous reasons, people can have type 2 diabetes with insulin resistance. But that doesn't mean that you can't go on to get type 3C, that you can't end up with pancreatic cancer or something on the back of that, because it's a different cause altogether. And I think this can often be a confusion where someone will have type 2 diabetes and then almost the medical team may not recognize, in fact, they've now developed something else. So it is a complication really with some of it.
Yeah, great. And I think often what we do see is that some people can have type 2 diabetes for a long time and have really quite stable control, and then their control really becomes a challenge, and obviously that can be a red flag. So the next question is, does the liver also produce glucagon? This person says, I now have liver metastases, which has impacted falling blood sugar response.
The liver responds to glucagon, so glucagon is produced in the alpha cells of the pancreas. So obviously, if you've got metastatic disease in the liver, the functionality of the liver is then impacted, and this is your stores of energy and the production of new glucose. So yeah, it's an additional complication to manage.
Thanks. Yeah, it can be really difficult and really challenging when you've got lots of other things going on as well. And the next question is, do you support stay in range and pushing for continuous glucose monitoring technology following or before pancreatectomy? There's quite a bit in there. I've certainly not heard of stay in range. So yeah. So this person's had surgery to remove either part or all of their pancreas.
The continuous glucose monitoring aspect of it is very much a kind of local policy. There are national guidelines around it, but there's still a little bit of a kind of postcode lottery with regards to continuous glucose monitoring. So it really depends on local guidelines. So sometimes I will approach a GP and say, this is in this person's interest, can we facilitate this? And most of them are reasonably accommodating, because it can make a big difference. And we know that if you've had like a total pancreatectomy, for example, then it's really challenging managing blood glucose levels, and having something where you can monitor continually is absolutely amazing. It really makes a huge difference. But just because I believe in it doesn't mean to say that we can access it for everybody. It would be amazing. But yeah, and the time in range, what is, can we expand on that?
So it's yeah, I've not heard of that. It's stay in range. I don't know if that's
probably
some sort of
linked to the
initiative
time in
or-
range, I would assume, because we tend to look quite a lot at the time in range, which is that 3.9 to 10 that Bev was talking about, where we're basically trying to get most of the time within that range, knowing that it is going to go up sometimes when you've eaten, it's going to go above. And at times, if you've done more exercise, if you probably didn't have enough carbohydrate or something, you might bottom out a little bit, so go drop below that 3.9. But I must admit, there is a lot of focus nowadays as well on the time in range, so trying to get more of your time within that range. It's not, you're never going to get 100%, or I don't think I've seen anyone with 100%, but it's trying to increase the time that you're within that range, really. So yeah,
I think it comes back to this kind of individuality as well. If you've got somebody who's got a really challenging issue, like you don't have glucagon as well as insulin, then actually, you know, not being too tight is a really good place, because sometimes when you go down, it's really tricky to get back up again. So it's kind of, what are you actually trying to achieve? And I think that needs to be at the core of every, you know, of all the management. But I would definitely say that having more of the tools to monitor definitely makes it easier.
Great, thank you. Yeah, because we did actually have some questions before the event, and some of those were on that same about views on continuous glucose monitors. And the question, part of the question was that continuous glucose monitors are to be made more widely available to type 1 diabetics, but should they also be made widely available to patients with cancer that impacts blood glucose? I guess what we're saying is that yes, for some people that is really appropriate and really beneficial. So yeah, I'm presuming that the person that asked that question, it did actually have the total pancreatectomy, and yeah, they've said how useful the Daphne course was. So for people that don't know, the Daphne course stands for dose adjustment for normal eating, and I know, you know, a lot of people go on that course. So this person said how helpful that was, and really having had a total pancreatectomy, they feel as if their management is much more in line with a type 1 diabetic. And
yeah.
I know we haven't.
I would argue that it's actually a little bit more complex. To be fair.
But for those who've had it for a while, we might do a little bit more sort of dose adjusting based on the carbohydrates, which is kind of how that's kind of the Daphne approach in terms of looking at the carbohydrates and adjusting the insulin according to what you've got. And it's very individual in terms of what that relationship is for you. But yes, certainly I know locally the course that we offer, similar to Daphne, we do offer it for some of our type 3C diabetes and people with type 3C diabetes as well, because it does correlate. It's just, we know with type 3C, it is that little bit more complicated because of the enzymes and the glucagon as well, but it's a similar approach really.
Brilliant, thank you. And I know it's, often for people with pancreatic cancer, they can, we have to look at the whole picture, and often people are sadly really quite poorly and are really struggling with their eating. And I guess, it is very much an individualized approach, isn't it? And recognizing that for some people we'll accept higher blood sugars because we're looking at the bigger context of all the challenges that person is feeling and is experiencing. Okay. Next question is it vital to take fast acting insulin like Nova Rapid 15 minutes before eating?
Again, this is very much horses for courses, but literally as soon as you start eating, if you've got your enzymes kicking in at the same time, and it's very much about how your body is processing food. So if I look at somebody who has maybe type 1 but doesn't have, so has pancreatic enzymes, we would also recommend doing your rapid acting 15-20 minutes ahead of eating, because literally as soon as you start eating, your sugars are rising, but the insulin takes about 20 minutes to kick in. So if you fit that profile, then yeah, absolutely, it's great to do it. In the real world, sometimes it's not, you forget, you don't know what you're going to eat, so if it's possible and you fit that profile of your sugars starting to rise as soon as you eat, then yeah, it's a great thing to do. It gives you a much smoother postprandial reading and you have kind of less time out of range. But it's whether that fits for you. I mean, if you've got any issues with gastric emptying, the timing of the insulin might be a little bit later. So yeah, if you fit that profile, definitely a good thing to do.
Great, thanks. Okay, next one. You showed an insulin pen.
Yes.
For type 3, can you use the new attachment technology to monitor levels?
What do you mean, the NovaPen 6, is it, that tells you when you've done your dosing? Is that what we mean?
We might,
just looking into blood glucose monitoring.
Yeah.
Yeah, or if the person that asked that, so it was Trevor that asked that, if maybe you want to pop something in the Q&A and then we can come back to that, just to clarify exactly what type of insulin pen. That would be helpful. So we'll just move on to the next one in the meantime. Okay, so this person had a Whipple's, so that's just so people know, that's the most common type of pancreatic surgery where the head of the pancreas is removed as well as other surrounding bits. So they had that surgery in 2016. They're taking pancreatic enzyme replacement therapy. Their recent HbA1c test, which is a blood sugar, which is a test to look at their blood sugar control over the last 2 to 3 months, shows 42.
Yeah.
GP has told them that it's a precursor to type 2. He says type 3C is not recognised by the NHS and should just change his lifestyle. This person's also having input from the hospital at the moment as well.
I work in the world of diabetes. The thing about GPs is they're terribly generalist, so they don't necessarily have a finger on the pulse of everything. So in the world of diabetes, type 3C is very much recognised. And as somebody who has a Whipple's where bits of your pancreas are removed and we don't know how much functionality you've got in your beta cells, then I think an HbA1c of 42, you're doing pretty well, to be fair. There is a good chance at some point you will have to have some escalation in treatment that you might not be able to manage it all the time with diet, etc. But I would say that you're obviously doing pretty well, to be fair.
Yeah, 42 is a good number.
Yeah.
Really good.
Yeah, definitely. So I guess it's just a case of keeping an eye on that, isn't it? And recognizing that, yeah, for some people that have had surgery quite some time ago, you know, they may never get to the point of developing type 3C diabetes, but it's important that that's monitored as part
Absolutely.
of follow-up or whatever.
Absolutely. It's because you cannot, when you go in and do a surgery on a pancreas and you're taking bits and pieces away, you can't guarantee how much is left behind and what the functionality is going to be. But clearly you're producing some insulin, and it's just whether that changes over time, and then that can be addressed. But yeah, type 3C is definitely a thing. We didn't just make it up.
Okay. So there's a question here. We have familial instances of both type 1 and pancreatic cancer. They've written different family members. I'm not sure if that means different sides of the family. Some of us are tested yearly for signs of pancreatic cancer. Would regular testing for type 1 also be recommended as routine?
I think probably, I mean, if you're concerned about developing type 1, I suppose, you know, you could ask for an HbA1c to be done annually. I don't really see there would be massive harm in that. But again, that's probably down to kind of what the GP thinks. But I mean, if you explained your risk, you know, and your concerns to a GP, then I don't think it's a massive drama to do an HbA1c on an annual basis.
Yeah.
Especially if it gives peace of mind.
Yeah.
Yeah. Yeah. Great, thank you. And another question here is, I was told to stop my metformin on the 7th of April this year, and taught blood testing without it by my GP. Sorry, I'm just reading this out, and it's I haven't had adequate help yet. My blood sugar levels are running at between 14 and 17 just now. What advice can you give? I'm seeing the diabetes team on the 6th of June, and he's just started chemotherapy today. Yeah, so he's obviously stopped the metformin fairly recently, but his blood sugar levels are running between quite high, between 14 and 17. He's having a review, but we're also we've got chemo thrown into the mix as well there.
Yeah. It's good there's a diabetes appointment.
I would be inclined to see if you could speak to, I mean, I'm not sure when your review is, I'd be inclined to say, if the GP has given you a monitor, you would anticipate the GP would expect some feedback on results. And I think blood sugars are 14 to 17. I would want to act on that, whether we start a little bit of background insulin. But if you want to speak to the specialist, then that might be worth trying to have a conversation with them to see what their input. If that was one of my service users, I think what I'd be inclined to do is, you know, discuss maybe starting a little bit of background insulin.
And I think if you've got chemo coming up, it's worth chatting to the team as well about what your blood glucose is doing when you're at that appointment as well.
Yeah, it's whether your chemo includes some steroids as well, which can cause a bit of pandemonium with your sugars.
Yeah.
Yeah, definitely. I guess it would be interesting to know why the metformin was stopped. I know for some people metformin isn't great. It can cause a bit of, you know, bloating, sometimes a bit of loss of appetite and things like that. So it's often not one that is chosen for people with type 3C, given some of their difficulties that they may be having as a result of what's happening with the pancreas. So, and, you know, the digestive issues that can occur as a result. So, but yeah, their review was on the 6th of June, so it's quite soon. So, yeah, I think we were saying that we'd want something, some action there with some intervention. then Trevor has kindly chipped in with following that question about the insulin pen. So he's referring to the Libra equipment attached to the arm to monitor. And he's asking, is this readily available via the GP? Testing by pricking the finger is a major challenge with tingly fingers because he's having peripheral neuropathy.
It comes back to local policy. So in our locality, we do structured education and we do invite our type 3Cs, and we can facilitate a Libra for them. So it's about going back to your GP and asking your diabetes centre at whatever place you're having your treatment to see whether they can facilitate that for you.
Great, thanks. We've had another question about how much Creon a person should be taking. Can you say more about the impact of Creon on blood sugars?
So with Creon, I think it's difficult to say how much you would need to be taking because it's very much an individual thing. Certainly, if you're not, people who aren't taking enough enzymes will generally have bowel issues as well. So they'll have very, very loose stool. I know it sounds an awkward discussion, but you can get stool, floaty stools, quite greasy stools, and it's a sign that your body's just not digesting. So chat to the team, whoever prescribed the Creon. I think it's worth a discussion with them in terms of how much you need to be taking. But I tend to generally ask people, okay, what are your bowels like? What are the stool like? So asking questions about that to see, is your body actually managing to, are you getting the digestion that you need? And that's generally when people will look at whether they need to increase their Creon doses or not. So speak to your team, because we've got a wide range of doses people are on, and it's very much dependent on the individual, really. In terms of the impact on blood sugars, once again, that's going to be, are you actually digesting everything? Normally, when we digest, we release that glucose into the bloodstream. So when we have carbohydrates, we can kind of predict the impact it's going to have on our blood sugars, because we sort of know that's going to turn to glucose, and that's going to be the sort of result. You've got a bit of a feel, but obviously if you haven't taken enough enzymes, not all of that carbohydrate is going to be digested, and you're not going to get that same result. So getting that enzyme dosage right can be quite important, because it does then help manage the blood glucose, because you can predict it a little bit more. So likewise, if with the enzymes, it's just trying to get it's basically just trying to get that dosage right with what you're eating. And generally, there are some dietitians who can advise around it, who've got quite a lot of experience in that. I must admit, I tend to generally refer it to my HPV colleagues who deal quite a lot with the Creon dosing. But certainly speak to the prescriber, I would say, just to get some further advice around it.
Okay, great. Yeah, I mean, I guess, we speak to an awful lot of people about Creon dose and how to take it effectively on our support line. So yeah, I encourage you to give us a bell if you'd like to do that. Usually a starting dose of Creon. So we would recommend that a person has the 25,000 unit capsules. So Creon comes in 2 different capsule doses, so the 10,000 unit capsules and the 25,000 unit capsules, but you would need the 25,000. And usually a starting dose is 1 to 2 with a snack, and 2 to 3 with a meal, we would generally say. And then, as Karen was saying before, most people will need to increase that dose, and the way in which we know if a person is taking enough Creon is by looking at their symptoms. So obviously closely monitoring their weight, because if somebody's not absorbing their food correctly, then we would expect them to be losing weight. They can have a lot of bowel symptoms, as Karen was saying, but they can also have other things that are perhaps not talked about so much. So things like a lot of bloating, a lot of wind, a lot of indigestion, sometimes nausea, feeling full very quickly just after eating small amounts of food. People might talk about taste changes. They might describe a metallic taste. So these are sometimes things that are not mentioned so much. So yeah, it's a case of trying to tweak the dose and making sure that you're taking it. And as you should be. So taking the first capsule as near to the first mouthful of food, not taking it with hot drinks, yeah, those sorts of things. But you know, if you did want to chat to us on the support line about things like that, or chat to your team, as Karen was saying, then that might be helpful for you. And yeah, generally speaking, once someone's absorbing correctly, particularly thinking about their carbohydrate absorption, we would expect the blood sugar levels to go up. So it's good to be aware of that. And although that can bring more challenges, it is really important that people are absorbing their food effectively. And then we've got one more question, so that's quite good timing. Someone's asked, do you recommend ketone testing when sugars are high?
Slightly quite a tricky one. I mean, if you think you don't have enough insulin production, then yes, we would recommend ketone testing. For me, it's kind of how are you feeling at the same time? Is it a postprandial peak? Do you kind of feel okay? If you feel a bit iffy, then you can do ketone testing. It's never a cut and dried or you know, completely clear picture. It's, you know, if we don't know how much pancreatic function, we don't know how much insulin production you do, and your sugar levels are high and you're feeling a bit rubbish, then maybe there is a place for ketone testing.
Okay, that's great. Thank you very much. So I think that's us got through all of the questions. So yeah, you can breathe a sigh of relief now. So thank you very much. So yeah, perfect timing. So yeah, we just want to say big thanks to Karen and to Bev, and also to everybody that's joined, and for asking questions. If you would like a bit more information about, if you feel like we haven't answered fully your question, or if you do want any more support, then please do consider getting in touch with us on our support line. So you can call us or email us, and it would be great to be in touch with you. We really do hope that you've found the webinar helpful. When you leave, you'll be taken to an anonymous feedback survey, and we'd be really grateful if you would fill this out. It should only take a few minutes, and your thoughts are really helpful for us when we're thinking about planning future events, so that would be really appreciated. Yeah, so that's it. Thank you so much for joining, and we hope that you can come to another event in the future. Bye for now.
Thank you.